ان احنا by end of this presentation هنقدر describe the trauma primary survey for conflict trauma patients and identify signs and symptoms for acute life-threatening conditions caused by burn injuries and the critical CADCD actions for burn injuries. Burn injury in conflict setting. Burn of flame or burn injuries are the most common type of burn injury. History of flame burn in any closed space may suggest an inhalation injury. Patients with burn may have sustained multiple other traumas like blast injuries or falls or penetrating injuries as they escape from the fire. Safety considerations in case of conflict. This is according to local resources available. The most important is scene safety. Trauma primary survey. In case of conflict, the only difference between trauma primary survey and conflict and other trauma primary survey is that we add C in front of ABCDE framework. C means catastrophic bleeding. If there is any catastrophic, obvious bleeding, spraying, or pooling blood, this may lead to this in just a couple of minutes. That's to ensure, in case of conflict, we have noticed that catastrophic bleeding. Regarding the airway, if there is any trauma to the airway, to the head and neck, if there is any suggestion of cervical neck injury. Regarding the breathing, if there is any increase in water breathing, there is any crevitus, there is any absent sounds, there is any circumferential pain regarding the chest or the abdomen. Regarding the circulation, as we mentioned, external bleeding, we also notice the pulse, the cold skin, our skin temperature and color, also blood pressure and capillary fill time. Regarding the disability, we noticed the consciousness of the patient, GCS of RP slow. We check the pupil, we check random blood sugar. Regarding the exposure of the patient completely. We remove any tight clothes with jewelry. We remove any wet clothes. We avoid hypothermia. Keep the patients dry and warm. Acute life-threatening conditions. Regarding the A is obstruction of airway. Regarding the P, inhalation injury or circumferential injury, permanent injury to the chest or abdomen. Regarding the C, pulselessness or cardiac arrest or shock. Regarding the D, disability or disturbed conscious level. Regarding the E, extensive pain. Remember that in case of conflict, people who initially appear uninjured may have hidden life-threatening injuries. So it's important to reassess trauma patients. After we complete the primary survey, we're taking a sample history. Then we go to trauma secondary survey after we have already completed CADCDE approach. We perform a detailed head-to-toe examination of the patient. Assessment and management of burn, airway burn and inhalational injury. We check for burn in head and neck, any swelling, any swallowed lips or tongue, any extensive burn face, any soothes appears, any permanent nasal or facial hair. They all suggest inhalational injury. For burns, we look for skin color, depth of burn. We manage severe pain, give tetanus. Burn depths, it differs superficial, partial thickness, and full thickness. This examples of superficial, partial, and full thickness. Calculation burn area by wall of mind. Special considerations regarding the pediatrics, as they have large head and smaller limbs. Intravenous fluids for permanent single patients regarding the Parkinson formula. Intravenous fluids for permanent mass casualty incident. And this is the most important point of this literature. How we calculate, or how we give fluids for mass casualty incident. This recommendations from WHO clinical teams. It's called Technical Working Group Preparedness Formula, or TWGP formula. Below 20% of total body surface area permit, we give oral fluids to cells. No intravenous fluid recommended. From 20 to 40%, we support with ORS, oral hydration solutions. And we consider intravenous fluid as appropriate regarding the clinical status of the patient. We give ORS at a volume of 100 milliliters per kg per 24 hours. Above 40%, we give 100 milliliters per kg per 24 hours intravenous crystalline and drink as able. Consider need for more fluids in children below 15 kilograms. Actually, this is the main point of this lecture. In case of conflict, we don't have the resources. So we change the crystalloid with oral hydration solutions in most cases. And actually, the WHO gave us a preparation formula for ORS. We can homemade it. For electrical injuries may look small but can cause extensive tissue and muscle damage, including cardiac muscles. And we have to adjust, in case of conflict, the fluid to electrical curve. We give by Bartman formula 4 milliliters. And we targeted urinary output from 1 to 1.5 milliliters per kg per hour until urine is clear. Disposition considerations, all deep wounds for surgical review at specialized unit using SPAR approach. Remember that the goal of initial assessment is to manage CAPCD and other life-threatening condition, and the goal of acute management is to prevent secondary injury from poor oxygenation and decreased perfusion, control pain, and plan ongoing care. In summary, the trauma by MSFA approach for conflict trauma, it's called CAPCDE, and we both see for catastrophic bleeding. Signs and symptoms of acute life and limb-threatening conditions resulting from burn injury. Critical CAPCD actions for acute life conditions resulting from burn injury. And thank you.